About 15 years ago, I was working in a neighborhood clinic not far from here, in the Fairhaven section of town. I was sitting with a middle-aged woman. Let's call her Miss Rodriguez. She had diabetes, and I had to adjust some of the dosages of her medication. And it was important that she understood what I was saying, because when she got home, she had to take the right pills. But as I tried to engage her in conversation, her eyes remained fixated on the exam room floor. She wasn't looking up at me. So I tried explaining it slower. I tried explaining in different ways. But she still wasn't engaging. And I was getting impatient. I had a line of patients in the waiting room. I had to move on. So as Miss Rodriguez got up to leave, she finally looked up at me. And she asked, "Doctor, remember about that kid that was shot and killed around the corner the other day?" And I replied, "Yeah, I saw it in the news." Then she replied with the harrowing truth. "That kid was my son." And for all my training, for all the medical school residency training, I felt powerless to help her. I was stung with the sense of futility. And I offered her some quick words of consolation and moved on to the next patient. But it was a small moment where I knew that my path would take me beyond the exam room. And I've since turned to a career in public service to try to tackle the big things that are impacting the health of my community. And in doing so, I've come more and more to understand that we have to move beyond a clinical framework when we're talking about improving health and look at the community fabric that has unquestionably been frayed under the stress of the pandemic, but has proven resilient and powerful in many unexpected ways. And today I want to share an example of that resilience. Think back about 2.5 years ago. We were seeing horrific images from Italy, the hospitals. The hallways were lined with stretchers. Patients were gasping for air. Many were dying because there were lack of ventilators. And as public servants, we knew that that scenario was going to be with us within a couple of weeks. And we had very few tools at our disposal. There were no tests. There were no vaccines. There were no treatments. We were just learning about the transmission characteristics of COVID-19. And we had one big, blunt instrument at our disposal: lockdown. Close the schools, close the shops, stay home, stay safe. Whatever you do, don't gather in crowds, because that's where an outbreak can happen. And on the eve of the pandemic, we were about to house our most vulnerable citizens, those experiencing homelessness, in shelters, cheek by jowl, right next to each other. A perfect situation for an outbreak. So with trepidation, I called one of our senior shelter operators. And I asked her, "What are we going to do? We can't house people like this. That's dangerous." And she replied, "Well, what does the public health guidance say? Let's start there. Let's start with the public health guidance." So I replied, "Well, anyone who's 65 or over or has 2 or more chronic conditions, they have to be out of the shelter within 48 hours or the results could be catastrophic." So we hung up the phone and agreed to get to work. We called our nonprofit partners, and immediately everyone sprang into action. A cadre of frontline nonprofits, understanding the mission, understanding the urgency, got together and figured out how to make it work. Teams of people called hotels, motels, universities, looking for individual rooms so these folks can stay safe. Community health centers deployed medical teams so that folks didn't have to come into clinic, but they could be assessed on site on whether they had symptoms. Soup kitchens began to individually package foods so they could be delivered or picked up, maintaining social distance. Methadone clinic providers, which is a life-saving medicine for many of the folks who are homeless, they started to deliver medications rather than expecting folks to show up at their clinic doors to try to make it work. Public health staff, even with very little knowledge, started to do contact tracing and advising frontline nonprofit staff on how to keep themselves and how to keep their clients safe. So out of what is initially a chaotic situation became an orchestration of activities, a set of activities that I call local service networks. And local service networks provided one of the most important unheralded aspects of the pandemic response. By protecting the most vulnerable among us and preventing outbreaks there, they protected the entire community. This is a core public health function. Protect those most at risk so that others can also be safe. Let's talk about public health. Public health has had astounding success over the previous centuries. It's an old field, it's a science-based field, and even before the advent of antibiotics in the 1950s, life expectancy had increased dramatically. And these were due to public health interventions, water sanitation, water chlorination, basic hygiene and living conditions. These were huge public health successes. And even in the modern era, there's been tremendous global success in public health. HIV treatment scale-up, vaccination scale-ups globally. And over time, public health, like any science, has grown in sophistication and specialization, and this is all very important. However, I believe in recent decades, that growing sophistication had a blind side. In valorizing expertise and the best and brightest talent moved to academia, industry, healthcare, even federal agencies. All the while, state and local public health infrastructure was on the sideline, subject to boom and bust cycles of funding, not able to maintain and attract enough talent for basic public health services. Luckily, during the pandemic, we had partners on the field to help us. Nonprofits who stood up and stood side by side with public health to protect our communities. Not only was that an effective way to respond to a public health crisis, I believe it did something very important. It built up trust on the ground level in public health. Now let's talk about trust. You may have heard that Americans don't trust government. That's wrong. Americans don't trust federal government. A recent poll by Gallup in 2021, in the midst of the pandemic, shows that 70% of Americans trust local government. Now, if your job is to rebuild trust in an institution like public health, where is a good place to start? Yes, of course, the CDC needs to rebuild and reestablish its reputation due to some of the missteps. But if we were to think that if CDC alone reestablished its reputation, that would be enough, we'd be mistaken. The real trust happens at the ground level public health, with relationships. A pastor of a large church having the health director on speed dial, that kind of relationship. A community health worker helping grandma with pills, that kind of relationship. A health inspector going to restaurants and a small business and showing them, like, this is how they improve ventilation so they don't have to worry about their customers getting COVID. That kind of relationship. Now, you may have also heard another problem in public health, that the public health system is fragmented. But you probably haven't heard why. The public health system in America relies heavily on federal funding and federal investments. Now, this investment is micro-categorized into various diseases and conditions, all of them very important public health issues. Opioid overdose, lead poisoning, HIV, diabetes, big public health issues. But what happens is when the micro-categorized funding trickles from the federal government to federal agencies to state, local, and ultimately communities, it's inadequate to cover the entire country, and even parts of the country that do get funding, it's inadequate to meet the challenge. Furthermore, this funding is at constant risk of being pulled. It's discretionary in nature. It may be there one day, it may not be there the next. And finally, this funding is in constant threat of being taken away. If someone does something wrong with the money, or a member of Congress thinks that someone does something wrong with money, it can be pulled. Now, some may assert, well, that's good because these are taxpayer dollars and we need to keep watchful eyes on them. However, the combination of inadequate total funding, the micro-categorization and limitations on the funding, and the threats that will be taken away, in my book, that creates the perfect system for the fragmented public health system we have. So, if we could solve this fragmentation issue, I think the possibilities are increasingly impactful. We saw it during the pandemic with these dynamic local service networks. Think about individuals who have unstable housing, have a very difficult time connecting to care. What if each of them were assigned a community health worker to make sure they don't miss a cancer screening or a blood pressure screening that you and I take for granted? Think about our neighborhoods that are food insecure, have very little access to food, and we're providing them with emergency food assistance in the form of food pantry. What if those food pantry foods had nutritionally impactful foods? It wasn't just something to solve a hunger problem, but we weren't just giving folks food that will contribute to chronic disease down the road. Now, we could go beyond these partnerships and direct services. Frontline public health and nonprofits and other leaders could team up to address the bigger issues, the social determinants of health, through systems and policy change. Think about organizations that are working on the front lines with individuals that are most impacted by drug addiction. These folks don't want to die of a fentanyl overdose. They need to get to treatment. These organizations could help them test their drug supply to make sure that what they're taking is not fatal. But to do that, we'll regard to team up and make policy changes so that organizations have the ability to do that testing. Think about, instead of food deserts, we facilitate and cultivate urban agriculture where we have fresh, sustainable, healthy food available in communities that do not have access to that right now. These are policy and systems changes, and it's possible if we can solve the fragmentation issue. Now, if I were to be asked my recommendations for what we need to do to solve the fragmentation issue in frontline public health, I would give 3 key recommendations. Number 1, frontline public health has to be well-resourced. Number 2, frontline public health has to maintain empowerment and authority. And number 3, frontline public health has to be flexible. Number 1, well-resourced. There's no getting around the fact that we need significant one-time and ongoing reliable investment in public health. Now, think if a fire department failed to contain a fire, would we take away their equipment? No. We would ask what happened, what went wrong, and what resources are needed to do it better next time. That's what we need to look at in public health. What resources are needed to do it next time? Now, additional resources are important, but it's not sufficient. Public health also has to stay empowered. There's been a dangerous narrative around public health being a nanny state, telling people what they can and cannot do. Now, there's legitimate debate to be had, of course, between individual rights and collective responsibilities, but authorities are being taken away under the guise of a self-defeating narrative that public health is just the nanny state. Public health is what we do collectively as a people to keep ourselves safe from health threats. Number 3, flexible. This goes right into the heart of trust. Public health, working on the ground, side by side with communities on priorities that matter to communities, with nonprofits that know the communities, churches, other community leaders, mayors, electeds. If public health has the flexibility to be in dialogue with all these stakeholders on the ground locally, we can start to rebuild that trust from the ground up, which I believe is very important and should accompany any effort to rebuild trust on the federal level. Now, if I could have that visit with Ms. Rodriguez again today, I would hope it would go differently. Of course, the medical doctor in me would be asking immediately, well, how's it going with your diabetes? How's it going with your pills? But I would understand that she may not be ready to talk about that. But I would have a community health worker go visit her in 2 weeks to go through her pills to make sure that she's taking them the right way. Ms. Rodriguez, I know you're hurting. You just lost your son. When you're ready, I can refer you to a counselor. but you may not be ready for that. We've teamed up with the community mental health organization that has trained all the salons in your neighborhood on community mental health first aid. So if you trust your hairdresser, maybe you can talk to her. Ms. Rodriguez, I know you're worried. You're worried your other son might do something rash. He's angry. Ms. Rodriguez, we're working with a community organization that specializes in stopping the cycles of violence. They know if your son might be at risk, and they can talk to him in a way he can relate to. The pandemic and its effects have been difficult and harrowing for all of us. But it has taught us a lot of lessons as community leaders and health professionals. And if I could have that visit again today, I'm hopeful it would go differently. I'm hopeful that leaders will learn the right lessons from the pandemic and build on that ground level trust that's been established. And perhaps we can help thousands, maybe millions of people like Ms. Rodriguez. And in that way, we can look forward to a brighter, more resilient, and healthier future for all of our communities.